it's Dr. Towfigh. Welcome to Hernia Talk Live, our weekly session. My name is Dr. Shirin Towfigh. I am your hernia and laparoscopic surgery specialist. You can join me for this podcast. Many of you are here as a Facebook Live or via Zoom, but know that you can also follow me on Twitter or Instagram at HerniaTalk. This episode and all prior episodes will be available for you to watch and share and subscribe to on my YouTube channel at HerniaTalk. Or if you're like me and you love listening to podcasts, we are also a podcast. Just find us at Hernia Talk Live. So I'm super excited because we have a new guest today. You know I love it when I have guests. Dr. Prashanth Sreeramoju is a hernia surgeon at Montefiore Hospital. He's a general surgeon like me with a passion for hernias. You can find him on Twitter at Prashanth Sreer2. And we were just chatting before this episode. Welcome, Prashanth.
Thank you, Shirin. It's a pleasure and an honor to be on your podcast.
Thanks so much. And again, you're like some of our previous, a lot of my guests, they're on the East Coast. So while I'm here, it's still sunny outside, 4:30 p.m. It's definitely well past your work hours, 7:30 p.m. in New York. So I do appreciate the time that you're affording us and my audience.
Thank you. I'm happy to be here.
Thank you. So we had actually quite a bit of questions for today's session. We thought I saw one of your talks. It was really, really high quality and good. I think it was at the AHS or maybe SAGES. I'm not sure. It was about TEP, totally extraperitoneal repairs, and you just did such a great, beautiful dissection. I said he would be a great expert to bring on. So I was hoping to talk mostly about TEP. And for those of you who watch me regularly, you already know what a TEP is, but there's TEP and there's TAPP, TEP or TAPP. And that's two distinct types of operations we can do, typically laparoscopically or robotically, but also you can have open extraperitoneal repairs. So maybe Prashanth, you can give us a little bit of since our audience is mostly patients, a little bit of insight into what is it we're even talking about.
Okay. So for the inguinal for the groin hernia repairs, I'm trying to be as much as talk in layman terms as much as possible so that everyone can understand. For groin hernias, there are different ways of approaching the hernia repairs, whether it could be like putting the mesh above the muscle or putting the mesh below the muscle. That's where when we talk about TEPs, TEP or TAPP, TAPP, we are talking mostly about laparoscopic or robotic surgery. So for TEPs, laparoscopic surgery, we put the mesh below the muscle above the lining of the belly called peritoneum. So we put the mesh above it. So we stay completely outside the belly so that the mesh will lay in where the muscle weakness is. So it goes exactly where it's supposed to go.
And the reason why first of all, just to clarify, all TEP and TAPP, pretty much all, although there are some exceptions, are mesh-based repairs. And the reason why we make the distinction is how you approach the area where you will be placing the mesh.
That's correct. That's correct. So all the approaches we are talking about is mostly mesh-based repairs. So for you want to know where the mesh should go. Is it like above the muscle or below the muscle? It all depends on your surgeon skill level and the patient and your type of patient you have. There are many factors involved why one would choose one over the other.
And it used to be well before my training time that when they developed mesh and people had hernias in the abdominal wall, they would just put mesh to cover the defect and the bowel would touch it. And we learned pretty quickly that surprisingly, a lot of people actually did okay with it, but in general, it was not a good idea to put mesh directly against bowel, especially with no barrier. And the best barrier is your own body's tissue. So the peritoneum is one of those. And then that's why the TEP and TAPP kind of differentiates how you access that peritoneum to move it out of the way, put the mesh in, and then close the peritoneum or have the peritoneum be a barrier layer between your mesh and the intestines. That's like the main reason why we do TEP or TAPP repairs.
That's correct. I mean, you said that interestingly because I was looking into the literature, the history of how the TAP or TEPs are started out. When they started out repairing the inguinal hernias, they started putting the mesh inside the belly. Of course, they are coated
Yes,
meshes, but
yes.
to protect the intestines, it's coated to protect the intestines. But still, they have a very high complications. Just
Mm-hmm.
slapping the mesh in the belly have a higher rate of recurrences and complications. And people try to find new ways to repair so to decrease the amount of complications, and that's
Yes.
how the TEP or TAP came into place.
Yeah, intraperitoneal mesh was considered the standard for early laparoscopic hernia repairs for the abdominal wall. And the inguinal hernia, therefore, were like, oh, we can do the same thing for inguinal. They found maybe not a good idea. Um, but you're absolutely right. That's kind of it's good to know the history. I gave a talk at Sages a couple years ago about intraperitoneal onlay mesh, and I felt like people didn't know the history, right? Why we do it, what's good and what's bad about it. And I dug through all that historical work with some of the earlier work with Ed Felix, and then before that with I'm blanking on his name, but an earlier surgeon. And they actually have papers where they kind of
Yeah,
discussed the history of how they went from intraperitoneal onlay mesh to extraperitoneal mesh and why that was better
I know. I
and
mean,
so on.
for me, I think it's interesting because I feel like for the same intraperitoneal repair with the protected coating works pretty much better for the abdominal wall, like in the umbilical hernias or any kind of hernias. It's pretty much the most commonly done procedure across the
Yeah.
world, perhaps, but it doesn't work the same for the groin hernias because I think it's maybe because of its pelvis is more like a 3D, three-dimensional. It's not two-dimensional. It's more
Yes.
three-dimensional. Your belly, your pelvic wall turns in, your
Yes.
lateral wall, your anterior wall, your like it's so
Like a salad bowl. I call it a salad bowl,
exactly.
It's like
So
a bowl.
it's very difficult to put a mesh in a three-dimensional intra-abdominal because there are so many ways things can creep back in above the mesh.
That's true. That's true. So, I have patients that ask me, 'cause my patients are quite educated when they come to see me. So even this week, they would say, are you doing this? Is this a TEP inguinal hernia repair or a TAP? And that's, many years ago, people would never ask me that. So, laparoscopically, there's TEP and TAP. Can you maybe tell me why you like to do TEP or TAP, or what are your thoughts about? Do you have a bias for TEP or
Yes,
TAP for
yes,
inguinal hernias?
for inguinal hernias, when I do laparoscopically, I love to do them by TAP, by TEPs rather than TAP. I'm mostly biased because you stay completely above the abdominal cavity, so there's less risk for injury to the intestines or any other structures inside the belly when you're doing a TAP repair, like a transabdominal preperitoneal repair. That's what it stands for. You try to get inside the belly first, then take down the inner lining, the peritoneum, and try to put the mesh in. But when you're doing the extraperitoneal, total extraperitoneal approach, you try to stay completely above that layer. Don't get into the belly at all. So it's a lot more better repair in terms for many surgeons. There is a big steep learning curve, but
Mm-hmm.
I think once you gain that, you know where you are. It could be claustrophobic initially when you're
Yeah.
learning because you're in a contained space and trying to develop the planes. But I think once you're used to it, I think it's a much more better repair than the tap repairs.
I love that you say that because I'm also a big TEP fan, TP. I think it's beautiful. It's like a clean operation. You're never inside the abdomen. You never see the intestines. I mean, you can choose to, but it's not part of the repair. And even if there's a situation where I have to go intra-abdominal, let's say there's bowel I need to reduce or something, I still like to convert to TEP
Yep.
and not have to just do a TAP repair. But you're right. You know, when I was trained in residency, the main surgeon who was doing TEP inguinal or laparoscopic inguinal hernia repairs was this community surgeon. None of the academic surgeons were doing it. And we learned from him, and he was doing TAPP, TEP. And to this day, my approach and technique towards it is very, very similar to how he taught us. And that was, shoot, 2022 years. Is that right? 22
Uh,
years ago. 22
wow.
years ago. Probably 25 years ago when he first taught me. But it was so new to me when people said, "Oh, TEP is very difficult. It has a high, steep learning curve. We like to do TAP." And I was thinking, I think TAP is difficult because you have to not only take down that flap, you have to sew it back in. I thought the
Exactly.
sewing in was just an unnecessary extra step that was more difficult. What's your thought about that?
I mean, you're absolutely right about it. I mean, the total extraperitoneal approach, TEP, is, I think it's a just beautiful repair. You can
Yeah.
stay completely within the space, reduce all your structures. And the biggest advantage for TEPs is you can just lay the mesh in without any fixation. Majority of
Yes.
the surgeons do it. For compared to TAPs, TAP repairs, a lot of surgeons try to sew it in. But
Mm-hmm.
TEPs, you just lay the mesh in, and it works just lays in properly, and you can see while you're taking out the CO2, desufflating that space, and you can see that mesh is staying nice and flat against the
Yes.
abdominal wall muscle.
Yeah.
Uh, I think that's just a beautiful repair. And I mean, it's interesting you say like you learned this like 20, 25 years ago, but it's still like we are like striving in terms of how we do it more safely and better. That is
Yes.
great. I mean, the reason, as you mentioned about Dr. Felix, like he and the few other surgeons talk about like the 10 commandments of hernia repair for groin hernias so that you can be safe, so can decrease the as many like complications, any complications actually.
Yes, very true. Very true. And when you teach your residents, do you have any problems teaching them TEP? Are they
No,
confused with the anatomy?
I think most of the times they are a little bit getting claustrophobic. That's what the best word I could think of
Yes.
for
Yes.
TEPs, because the anatomy is completely looking different compared to the open approach, because we are look behind the muscle. You see like you have a different way of it, but once they get used to the dissection, I feel like it's a better, residents can learn a lot faster
Mhm.
TEPs than TAPs, because you have to peel down the thin one cell layer
Yeah.
peritoneum. It's
Yeah.
challenging for a lot of residents to teach.
Yeah. Yeah. No, I agree. I agree. And then, so of course now there's the robotic technique, and a lot of people are moving towards robotic surgery for inguinal hernias. People who weren't comfortable with the laparoscopic inguinal hernia approach are now more comfortable doing inguinal hernias robotically, which is a good thing in that they're offering now minimally invasive inguinal hernia surgery, whereas before they weren't. They would opt to do open because laparoscopic was so difficult to master. But typically, robotic surgery is TAPP, right?
That's correct. Because just because robotic gives an extra, it's more maneuverable in terms like it can navigate yourself well transabdominally for
Yeah,
robotic, and
yeah,
also for robotic instruments to work on the total extraperitoneal approach is a little bit. I think most of the times you end up doing something called ETP, like ETAP, like enhanced like view for total extraperitoneal approach, which you
yes.
can do, but majority of the robotic groin hernias are done transabdominal preperitoneal repairs.
Yes. Here's a question. What are the complications of a TEP procedure? Number one. And what risk factors predict the possibility of getting these complications? So, what do you tell your patients about the risk of a TEP versus other other
No,
approaches?
for other approaches, most of the time the comparison for the open repairs, TEP repairs are in my hands. It's a lot better because you hardly see any nerves which you want to
Yes.
like and the mesh won't go against the nerve because the whole purpose of hernia repair with mesh is the mesh try to create this scar plate, and we don't want get that nerve get trapped in that scar plate and cause
Mm-hmm.
chronic pain. I think that's one thing. And the major lot of my patients when they get the minimally invasive surgery with like like TEP repairs, they recover faster. Their early post-operative pain is much better than open surgery repairs.
Yes.
Uh,
True.
the the complications in terms apart from bleeding and hematomas, it's pretty much the same for both surgeries. I mean, I have my own published paper about hernia, groin hernia repairs. I mean, I have to say that, I mean, it all comes down to there are three different repairs, right? We have a TAPP TAP repair, you have TEP repairs, and you have open repairs. They're all mesh-based repairs. But if you compare all three, I think the major most of this there's no real difference between all three procedures. However, TEP and TAP do far better on patients who are morbidly obese, who are
Yes.
BMS 35, above 35. The chronic pain and early pain is a lot better than
Yeah.
open surgery repairs.
Yeah. Yeah. Very true. Yeah. For the, you know, I there's a paper out there that I was involved in that looked at open lap and robotic hernia repairs for inguinal, open lap and robotic hernia repairs for ventral. And they took surgeons and they said, what do you do best? And they like, so I said, okay, I think I'm really good at, let's say, I'm going to make this up, laparoscopic inguinals and open ventrals. They're like, okay, Towfigh, you only enroll your laparoscopic inguinals and your open ventrals in this study. And some of the surgeons says, I do a really good open inguinal. And okay, so you surgeon, you only enroll all your patients for the open inguinals. And then someone's like, I like to do robotic or laparoscopic repair. That's what I'm really good at. And then that surgeon would only enroll in that. So basically, they took whatever you did best and enrolled you into that arm of the study. And then they said, okay, let's compare. If you
Yeah,
have a really good inguinal hernia surgeon, how do they do against a really good laparoscopic surgeon? You know, it's a great little
yeah,
paper because it kind of proves the point that if you're a good surgeon at what you do, your outcomes will be good regardless of the technique. Um,
exactly.
but anatomy is anatomy, right? So there's nerves that are at risk with open surgery that are not really at risk with laparoscopic.
That's exactly right. I mean, we kind of save a lot of headache. I mean, even for the news, I mean, and also in terms of the budding surgeons, the new surgeons who are coming up, they're getting a lot more trained in MIS approaches, laparoscopic TAPs or TAPs,
Mm-hmm.
compared to open surgeries. I
Mm-hmm.
mean, I personally feel my residents are a lot more comfortable doing TEPs or TAPs than open surgeries because as the, my mentors are kind of retiring. I mean, I'm right at the cusp. I had an advantage of getting open and laparoscopic skills.
Yeah.
But the current residents, I mean, not many people do open repairs anymore, unfortunately. There are very few.
Well, I do open mesh and open non-mesh repairs, right? Shouldice, McVeigh.
Yes,
And I feel that the chief residents, especially the ones that are going into critical care trauma, MIS, the ones that they know they're going to be taking general surgery call, they all want to start scrubbing in with me towards the end of the year. Because
that's correct.
they want to know how to do a good open inguinal hernia repair because they don't get to see as much of it nowadays.
I mean, I would say it's not. I mean, it's not too far for me to say there's like open inguinal hernia repairs, almost like when I'm looking at like doing a Whipple like for a pancreatic surgeon because very few people do it and very limited number of is only certain number of cases.
Yeah, it's true. So when I have patients that come in, they say, I want like a non-mesh repair. And then I ask, and this is like this week, totally healthy guy, small hernia, fit, wants to be like, do all his exercise, hiking, gym, etc. And male. And he came to me because he was told to do a laparoscopic hernia repair. And he wanted to come to me because he knows that I do, non-mesh repairs too.
Mhm.
And he was worried about mesh. And I said, listen, you're young, you're healthy, you're fit. Your hernias are small. You seem to have hernias on both sides. You're the perfect patient for a laparoscopic inguinal hernia repair, and I prefer to do those TAPP.
Exactly.
And he was shocked because he thought I would definitely say, oh no, like better that you don't get mesh in you, or that you can get mesh reaction, or but if you look at all comers, tissue repair, non-tissue repair, mesh, no mesh, open lap robotic, the laparoscopic repair done well has the shortest recovery, right?
Yes.
Best long-term results, lowest recurrence rate, and the lowest chronic pain rate.
That's correct. I mean, you're
Yeah,
absolutely right. Because the non-mesh repairs are good in certain instances. Like you have to wear, they usually follow very strict criteria. Like
yeah,
you have to be like skinny person, a small hernias, and
yeah,
not really highly active people. Then you obviously, but I think the best way, you have to understand the pathophysiology of the hernia, right? Especially for the groin hernia, it's more of a wear and tear of the muscle. You're not developing a hernia just because of there's an abnormal defect. I mean, in some people, if it is an infant, pediatrics, that's totally different. They do non-repair. But if in an adult, it's more of a wear and tear problem, and
yeah,
your tear in the muscle getting bigger and bigger. And when you start sewing the mesh, like only with the tissue repair, sometimes you may not get the greatest effect. The best effect you could get is like putting a mesh in, and a lot of meshes out there right now. If the mesh is placed in a proper location and safely, nice
yeah.
and flat, I think it's the best option any person can get.
I agree. And going back to the question, what are the complications of a TAP procedure? Um, how do you view complications of TEP versus TAP?
The most of the complications for the TAP versus TAP is mostly comes from the potential injury, visceral injury, like injuries to the intestines inside the belly when you're entering the belly itself.
Yeah,
I think that's why the way you get into. And sometimes, if you don't sew the flap, the inner lining, the peritoneal flap, sometimes the tissue, your intestines can creep inside and then cause small bowel obstructions and all.
yeah, that's
Uh,
the internal hernia of the flap.
and exactly,
That's
internal
definitely a
hernia,
complication that you see with TEP. Sorry, you see with TAP,
TAPS,
TAPP, and unless you have a accidental hole in your TEP repair, you should not see that at all.
exactly. And also, you're not making any cuts on the peritoneum, so it decreases the chance of any additions inside the abdominal cavity. So that's one of the advantage for the TEPs.
Yeah. But one disadvantage is you don't really see what's going on in the abdomen.
That's true. That's true. Also, you don't really know. Like sometimes, if you're not careful enough, how you uh, getting the flap down when you're doing a TEPs, because you're completely above the all the small intestines and colon. If you're not careful enough in terms of how you're using your energy devices and all, you have to be very careful. It's not definitely it's not for everyone, but if you can do it, I think that you can get a very good results with it. And
True.
just to give my own experience, it'd be interesting for you to know. So I had a patient one time came into the emergency room with a large bowel obstruction.
Mhm.
With basically his colon got incarcerated in the groin, in the left groin,
Left side, uh-huh.
left side, and had came in with large, like very distended abdomen. Uh, so all his intestines are dilated, they're wide and big. So first I want to see how the intestines are. So I went in transabdominal to look
Yes.
inside
Yeah.
to see how the intestine is, like make sure that there's nothing is dead, they're viable. So once they're viable, once I made sure, and once I reduced all the intestines are viable, now I don't have any space to repair. I thought I will just continue do a TAPP repair, but I don't could not able to do it because
Yeah.
I don't have any space to work laparoscopically.
Yes.
You know what I did? I ended up converting to TEP, like total extraperitoneal approach.
Oh, I do that all the time.
Yes,
Absolutely.
exactly. You put a balloon and just create the space. Now you have a CO2, which is keeping the space open for yourself, and you
Yes.
can put good mesh repair. And that patient had bilateral inguinal hernia. I ended up fixing both hernias at the same time, and the patient did great. I think that's one of the biggest advantage.
Yeah, that's what I was saying is that even if I have to look inside, let's say to reduce bowel, I would go back to using TEP again. I would just, but you have to close that peritoneum at the belly button, otherwise you lose some gas.
That's correct. That's
Yeah.
right.
Yeah.
So
Yeah, I think it's perfect.
I know it's quite interesting how you can use different planes to help yourself for the safety of the patient, and also for better outcomes.
Now, one issue with TEP, TEP is if someone's either had surgery in that space already, like a prostatectomy, especially specifically open prostatectomy, or if they've had um well, did you read the letter by David Chen where that he shared his TEP
Yeah.
complication?
Yes, yes. Like open prostatectomies, anyone who has suprapubic catheter placement, anyone who
Mm-hmm.
has the bladder cystectomies. I mean, all
Yes.
are, and especially even more painful are the uh, lymph node groin dissection for deep inguinal dissection.
Oh, yes.
They have you lose that plane in that scenario. I would try to go tap approach, like I do them like mostly robotic, and at the same time if the patient is not obese, I would just go open repair. Listen,
Yeah.
at the end of the day, you need to have all the tools in your hand so that you
Mm-hmm.
can do a safe and safe procedure for the patients, and that's what it matters. Being safe
Yeah.
is a good
Well,
thing.
that's the thing is you have options. The open repair is a perfectly good option, especially in someone who's had surgery in that area, like you said, for bladder surgery, prostate surgery, which is
Surgery.
also bladder surgery, really,
Yes.
um, and any type of really bad kind of lower pelvic surgery.
Right.
The letter I'm referring to is uh, this patient, I guess, had perforated diverticulitis or something in the past and just had the antibiotics and got better. But as a result of the recurrent episodes of diverticulitis, the colon was really scarred in to the peritoneum. And then the surgeon went in, TEP, TEP, and number one, didn't really know that history,
Mhm.
and went in because and stayed extraperitoneal, so away from the intestines where you don't see the intestines, and did their dissection, did perfectly good surgery. And then 2 or 3 days after surgery, there was stool coming out of the
Mm.
out of the trocars. So what had happened was in the dissection of the peritoneum, pulling everything down, there was an inadvertent pressure, pulling, tugging, tearing, or something of the colon, which had been stuck into this area, unbeknownst to the surgeon, because he stayed away from the intestines. Whereas if he had gone inside and seen or known the history, maybe this complication wouldn't have happened. It's unclear. But that's one of the complications with TEP is that you're not seeing at all what's happening inside the abdomen, which is fine for most people. But if you've had any pelvic surgery, it's not, you got to be more careful.
Absolutely. Like if you need to know your patients well, and sometimes a lot of patients do end up having a CAT scan, and having a look at the
Mm.
CAT scan would
Yeah,
also help you in terms
yeah,
of uh, assessing the anatomy well better.
yeah,
I've been, I mean, as a, it's in, I mean, when I was a resident, Sharon, I have to tell you, like a lot of times, hernia, I've been ingrained in my brain that hernia is more of a clinical diagnosis. I agree, it's more of a clinical diagnosis, but the hernia surgery evolves so much that
yes,
I think you need to have more than just history. You need to, because ultimately we are dealing with anatomy, like the musculature of the abdominal
yeah.
wall.
For
And
sure.
having a CAT scan to tell you like what things, what I need to be careful of, what I think it helps a great length for a surgeon.
Oh, absolutely. And it's so important to read your own CAT scan and not just a report, because the what the surgeon needs to get out of it is different than what the radiologist is telling you necessarily.
I 100% agree with that. As a surgeon, you need to know how to. It's in like I remember when I was a resident, we are going with my mentor, like going to the radiologist, like and sit down with them and talk to them, like, oh, let's review the CAT scan of this patient,
Uh-huh.
that patient, right? So
Yes.
it's definitely a skill which you'll need to learn because ultimately you are operating and you have the advantage of seeing the patient and you have the advantage of looking at the CAT scan and you can combine both together. And that's the man, it's you'll give you a great opportunity for the patient in terms of outcomes.
So true. Here's another question. If you perform a unilateral hernia repair with TEP procedure, can you do a repair on the other side if a hernia develops there, or can you only enter the TEP space once? That's a good question.
It's a very good question to be. I think you should able to still do it because
Yeah.
most of the times when you're doing a TEP on one side, you, I mean, you probably like 2 centimeters at the maximum, like on the contralateral side of it, a little bit cross the midline, 2 centimeters, but you don't entirely dissect that space. You can definitely go in that space again to fix the hernia.
Yeah,
And
absolutely.
yeah, and and if the surgeon is if things too murky, like you can always do a tap repair. You go back, go in the abdominal cavity and repair. But I think you can still do it for unilaterals for sure.
Yeah, the if you do so if you use a balloon that automatically dissects both sides, let's say, there are techniques that can reduce how much of the other side is being addressed. Um, but let's say for argument's sake, that whole entire side was also exposed. It's not that much scar tissue. Depends on how much time has gone by, but you should be able to access that other side fine. Um,
Yeah, definitely. Like we even with the balloon dissector, it will probably dissect the space below the muscle, but it won't
yeah,
entirely dissect the space. So you would still able to navigate yourself to take
yeah.
the hernia sac down to fix the hernia.
Do you prefer the laparoscopic tap or the robotic tap?
Do I mean, I prefer laparoscopic
Me too.
TEPs for majority patients. But having said that, if I have a big inguinal scrotal hernias or
Yes.
morbidly obese patients when they have very thick pannus,
Yes.
I end up like doing a lot like robotic taps on those
I co
patients.
I completely agree with you. I agree with
Yeah.
that. Let's see. If you have a significant but asymptomatic diastasis recti due to linea elbow weakness, can a TEP procedure be performed without worsening or enlarging the diastasis?
Yeah, I
Yeah,
don't think diastasis
unrelated.
would affect any patient, but most of the times for the diastasis, mostly we're talking about hernias on the abdominal wall, not really for the groin hernias though.
Yeah,
So,
agreed.
but just having a diastasis would not make the diastasis worse for the hernia repairs for groin hernias.
Yeah, there I've heard from some patients and some doctors have told them that it's their laparoscopic surgery that caused the diastasis, and there's just no evidence for that.
No, definitely
Right?
not.
Yeah,
We are not destroying the abdominal wall. We're
yeah,
just taking the innermost lining and we're not destroying anything at
yeah,
all.
agreed. Here's another question. Comparing TEP to TAP, is the mesh placed in the same tissue plane?
That's correct. It will
Yeah,
be placed in the same exact tissue plane,
yeah, same
just the
exact
line above
operation.
the, yeah.
Yeah, I just did a robotic tap on an incisional hernia in the lower quadrant, left lower quadrant. It was an anterior approach to a spine surgery, and they closed the anterior layer, but not the deep layers. So she had a bulging where the internal oblique and the transverse abdominis had pulled away. So I went in and did a tap, right? So I basically had to, but I explained to the patient that, I started in the abdomen and then I went outside the abdomen, right, in that plane. And she was like, "But I don't understand. Why couldn't you just stay outside, right?" So what do you think about robotic TEP procedures?
I think robotic TEPs, I think is perfectly good. I think there is a learning curve for it for sure. Not many surgeons do it because just because the instruments are still bulkier,
Yeah.
that you need to have that enhanced view. I don't think any regular TEP procedures are done for robotic. I think most of them are ETAPs, which is enhanced view total extraperitoneal approach. We start a little bit higher, but it's totally doable. I think Dr. Flavio Malcher from NYU has published his first series of robotic TEP repairs on that.
Yes. Yeah.
I think it's doable, but I think because basically because robotic instruments are so like in terms you have like more wrist motion, all this, so it just makes it a lot more easier to do TAP repairs robotically than TEPs.
Yeah. The arms need more space to move
There's
around.
more.
And so your typical TP you cannot do robotic, but an ETP, which it's basically extended or enhanced, where it's a much wider space, larger space, you can consider doing. It's just not worth the time and effort of it.
That I
I think.
agree on that for sure.
Here's a question about mesh complications and device complications. What resource database do your practices use to check on problematic meshes? I'm aware of a database named Device Events. This is patient, I think, is from Australia,
Okay.
which is designed in detecting and informing specialists of problematic medical devices. Obviously, for mesh procedures to be successful, specialists should be aware of any medical devices they use becoming flagged as problematic. Is this something that you use? And if not, what are your views on this being mandatory for all specialists to receive alerts about device problems? The database is at least 10 times larger and much more detailed than the FDA's MAUD device. I have not heard of device events.
No, I mean yes, I agree. I mean, from the patient perspective, it's a big thing. Like whenever we say mesh repair, like a lot of red flags goes on the patient. I mean, I'm not gonna every single patient I talk, hey, I'm going to do the mesh repair, but I tell them, listen, the standard of care for hernia repair is a mesh repair. That's a standard no matter what. It's all depends on how well the mesh placed and where
Yeah.
exactly it's placed. It's not the mesh is a problem. Having said that, to answer the question, there are definitely databases which industry does follow, like FDA, like European has a database also. Like whenever there is a I did some medical writing for company consulting for basically every single surgical instrument or anything. They have basically post-marketing surveillance data. They look into all the literature. If
The
any kind of
industry has it.
industry has it,
Yeah.
and it's mandated by the FDA and also European Union CEC. Like they have every country has its own database collection to make sure that they are doing the right what they're supposed to do. If they have unfortunately, if they have high complications rates, for some reason, they'll pull out. I mean, there are certain measures which are pulled out in my surgical industry,
Yeah.
right? Like, so, I mean, it's not like we are just working in a silo. I think single thing will be monitored
Yeah.
eventually.
The problem with MAUD and some of the FDA based devices is anyone can make a claim and it's not clear what, if a patient has a recurrence, is that really a device issue or a surgeon
Exactly.
technical issue? Is it, there are lawyers out there that are suing for hernia recurrence. It's not clear how they're going to prove that it's the device. And of course, the mesh companies will say it's not the device, it's the surgeon, and vice versa. So it's difficult to know each of those different um reports how vetted they are, because I've gone through that MAUDE,
Hmm.
MAUDE, that MAUDE
Yes.
database, and there's a lot of
Yeah, it's not clear.
questionable reports in there. So it's hard to differentiate like what's real, what's not real. Um, I think that's what's going to be true for any database that tries to track complications.
That's true. You're 100% right.
But I guess it's similar to car crashes, right? If you log every single car crash, is it the driver or was it the
Well,
faulty brakes? How do you know?
yes, I mean, I think your analogy fits right in for sure, because when you have a complication, if it's, I, is it related to mesh or is it because surgeon? I think it's different. I mean, as I say, like the mesh, majority of the times, whenever the patients talk to me about, oh, mesh, is it bad? I say, listen, mesh itself is an inert material. It doesn't cause any bad. Mesh, like they talk about, there's a lot of infections. Like, it's sterile. Mesh won't get infected unless there's infection spreads to it. But by itself, it won't cause infection.
Yeah.
So it's just a matter of having more awareness. I think that's important for us hernia surgeons.
Yeah.
It's our responsibility to talk to the patients about like what to expect and everything.
Yeah. Yeah.
Definitely.
Mesh infections are pretty bad complications. You never want a mesh infection. That's just that
Yeah,
destroys a patient's life for many years.
that's true. I agree. And on the average, every mesh infection a patient would undergo at least 2, 3 procedures to
Yeah.
clear off the infection.
Yeah. Yeah. It destroys your
Yeah.
life for several years. Yeah, absolutely.
Yeah.
Okay, next question. After you deflate the space at the end of a TAP, can you go back in if the mesh is not lying appropriately and or the floor is still floppy?
Oh yeah, absolutely. I think it's a great question. If you're not satisfied the way how the mesh laid in, you can uh, inflate that space again and
Hmm.
reorient your mesh. As
Yeah.
long as you're still there, you can absolutely reorient it.
Yeah, for
Oh,
sure. For sure. What kind of mesh do you use for your TAP TEP?
the most like the my go-to mesh is mostly 3D Max
Yeah,
mesh.
same.
And
Same.
majority of the times I have a standard way of doing it. Almost all my patients get like a large, like extra
Yeah.
large. Very few patients get large mesh. Like it's all about like having proper mesh overlap. Like you have to like getting down to the basics of hernia repair. Make sure you have enough overlap. Make sure you have
Yeah.
good mesh nice and flat, and
Yeah.
all those things.
Here's an insightful question. It says that we understand that mesh-based repairs may be the standard of care, but once you have a complication, what is the standard of care for that? How do people know about what to do with mesh removals? Um, how do surgeons follow? What standard of care do surgeons follow for mesh removal due to complications? From my experience, the standard of care has been, well, it's unfortunate this happened, but we don't know what to do. And here's a number to a pain management doctor. Good luck. Good point, honestly. We do not have a standard of care for how to handle complications after hernia repair.
Yeah.
And there's a
Uh,
lot of people out there that require, whether it's a, we do have a standard of care for recurrence, right? We do know what to do
yes.
with a recurrence. Do you want to review that?
Yes. Yeah, definitely. You have a standard of care for hernia recurrence. That's one of the
Yeah,
complications of a hernia surgery. So
yeah,
if you have a hernia recurrence from an open repair, the best way to fix those recurrence is to go posterior repair, which is like TAP or TAP repairs or TEP repairs.
yes,
But if you have a hernia recurrence from a posterior approach, it depends upon the skill set. Their recommendation is mostly to go anterior approach,
yes,
like open
open.
repair.
Mm-hmm.
Or if you are skillful enough, it depends on who did the surgery. Like if the mesh was nice, small, or it's
Yeah,
like moved, then you can go back. And I mean, there are instances I've went back and posterior approach repairs like TAP, like for a TEP repair, I went back in and looked for a TAP repair because the mesh basically got folded on its own and clamshelled and open up the hernia space.
yeah,
Or in some cases, the mesh was small. For the hernia recurrence, yes, it's pretty standard the way how we approach. For when it comes to the chronic pain, yes,
mm-hmm.
then that gets a little bit difficult because every patient is different.
Yeah,
I mean,
very true.
I would tell you. I mean, it's interesting. I mean, eh, to get the your car analogy, right? If you're fixing a car, you one thing is fixed, you just fix that and that's it. Because every single car is made exactly the same exact length, same thing. But we are here, we are not fixing cars, we are helping patients, and every single person is different. We
Yeah.
heal different. Like I heal differently. If I get a hernia repair by you, I heal differently than if by someone else. Like it's totally different approach. So it's not so chronic pain is something which is like very subjective in terms of it. Having said that, to answer the question, yes, when it comes to complication of a hernia pain, then we need to figure out whether hernia pain, the chronic pain, is it related to the nerve pain, or
Mm-hmm.
is it related to like mostly like a somatic pain, like related to the mesh itself? Like
Mm-hmm.
sometimes some surgeons use plugs in for the open surgery, which I don't like it. I hate them because I end up removing a lot of them.
Yes.
So in if that is a situation, once you like I for my standard way of to make it short, my standard way of approaching these chronic pains is to I do a pain map. First, I determine whether it's a nerve pain versus a non-nerve pain. If it is a nerve pain, then I send him to it's a multimodal, multidisciplinary management. You give a trial of gabapentin, neurontin, pain management, nerve blocks, and see if it improves. If that improves, that means that you will have a higher success rate in terms of doing a surgical procedure called neurectomy, and potentially also removing the mesh at the same time, because at this point you want to deal with what is most bothering for the patient. Like you need to take care of the pain, not really worry about the hernia recurrence. If it hernia comes back, but once you fix the pain, if the hernia comes back in the later on, yes, we can go back and fix it. But first, you need to
Yeah.
take care of what is the most imminent problem for the patient.
Yeah, most patients who have chronic pain after hernia repair do not need their mesh removed.
Yes,
That's one thing. And most also do not need nerves cut. It's usually a hernia recurrence or folding of the mesh or something or a single nerve which may be injured. So in my practice, my practice, it's mostly that. That's where you kind of have to be the detective to figure out what exactly do they need and what can you just not do and still have the patient do well. So if the mesh is perfectly flat and it's clearly neuropathic pain, just deal with the nerve. If it's vice versa, the nerves are totally normal, the mesh is folded, don't touch the nerves, deal with the mesh. So it's that thing. I feel like some patients, they go to surgeons and the surgeon just wants to do everything. Let's take all the mesh out and cut all the nerves. And that's not their problem. Let's say it could just be a recurrence.
true.
Um, or some surgeons, it's always nerve pain, right? So they go straight to pain management and they can't, what bugs me the most is when they have a laparoscopic repair and that they get sent to pain management for nerve blocks. There's no nerve that's being injured. You can technically injure the genital nerve or the lateral femoral cutaneous nerve. It's so uncommon. So you have to
Yes,
be really like really in the wrong space to do that. So you just don't see that very often. So, and those are never nerves that pain management knows how to inject anyway, right?
yes,
So, so it's that really bugs me. But for the patients to understand that this person's correct. There is no good algorithm. We have a great book. It's actually here. Let me just show you the Sage's Manual of Growing Pain. It's a
yes,
fantastic book. Patients can read it, but it's not meant for patients. It's meant for surgeons. I highly recommend it for anyone that does anything related to the groin or inguinal hernias because it goes to orthopedic, gynecologic, chronic mesh pain, nerve pain, everything you can imagine. Um, but it definitely tells you to tailor to the patient.
I agree. Like, I mean, you're 100% right about saying that, not every groin pain is related to the hernia repair.
Yeah.
Sometimes I had a patient, it just, I mean, it's interesting you say that. I had a patient with groin hernia repair, came with the same groin pain again, like few years after, saying that, oh, it could be like, then we are like, oh man, is it related to nerve pain or not? But you have to ask the good history and physical, like when
Hmm.
is the pain? He's saying mostly pain happens like when he's getting into the car, coming out of the car, like
Mm-hmm.
on hyperextension of his leg, like.
Yeah.
So then, you know what? Let's get an MRI, and it shows, like, sure enough, he has a tear in his adductor longus muscle, one of the muscle
Mm.
which you makes it when you bring your
Completely
gets your leg in.
unrelated. Yeah.
Totally unrelated, but
Yeah.
exactly, like, so you have to having a good history and pain mapping, all those things would help in, like, siphon out, well, like, basically identifying what exactly is the problem. Is it the nerve or anything?
So true. Here's another question. When do you use fixation in a TEP versus no fixation, and how do you gauge the size to use for mesh in a small patient?
Majority of the for the I never use the fixation device for TEP repairs because it's in the right exact space where I created. It's not going to move or anything like that. I think some surgeons use fixation mostly for themselves. I personally feel, because I mean,
What
listen,
about a
after
really
two,
large direct?
oh, if it is large direct, yes, I
Yes.
definitely did, for those things where you don't want to eventuate the
Yes.
mesh, don't want to bow out of the abdominal wall. Yes,
Yes.
but if it is the only cases, but other majority of times, I always end up using either large or extra large. I'd never go below large. I think if
Yes.
you're doing, it's a, I think if you go below large, that means that you did not create good enough space to put the mesh in.
Yeah.
That's my
Large.
my way of
It's
looking at it.
very uncommon for me to use a medium.
Yeah.
I have had maybe a handful in my career, really tiny Asian females, like super tiny, very petite,
Yes.
small build, almost pediatric in size. Um, yeah, there's no benefit to using smaller meshes usually. Next question, how long does it take for a scar plate to form? And can that healing be enhanced in any way by the patient, such as with compression underwear?
That's an interesting question, Sharon. I would say that, I mean, I think the healing maximum takes up to like 2 months, and after that, it's mostly a strengthening. After 2 months, it's not. There's no real healing happening up there. I don't think the compression has talking would have any effect underwear. Effect on healing process. Healing process is all about your body, how it
Yeah,
is heal, with the mesh and the surgery, and no hematomas or fluid collections. It's all depends on that, but it's
yeah,
nothing related to the external devices.
yeah, agreed. Although I'm appreciating more and more the benefit of massaging the
Yep.
area. Yeah, that can help. Next question. Are meshes used in robotic repair different than those for laparoscopic meshes?
No, they're exactly the
Yeah,
same.
exactly the same.
Yeah.
There are some meshes that are more difficult to place lap. Like for TAPP TEP, in my opinion, the pro grip meshes are more difficult to use because you have a smaller space and it tends to stick to everything. And some of the meshes are more difficult to put through certain trocars than others, but in general, it's the same.
Yeah, I agree, Sharon. Yeah, pro grip meshes are the meshes which has a grips to it. So basically, you can Velcro against the wall, muscle, and it just, you don't have to use a fixation device kind of thing. So it basically gets stick to the area. So it's good.
All right, next question. Assuming proficiency in all hernia repair techniques, what are the factors that influence the choice of technique of a specialized hernia surgeon, especially between TEP and TAPP? So since you and I are both TEP surgeons, like we prefer TEP, when would you go for TAPP?
I would go for a TAP most when a patient, as I mentioned earlier, if there's like a big, large scrotal inguinal scrotal hernia
Yes,
in
me too.
in males, or very big hernias, or if there is, if a patient who has, like as you mentioned, like a patient who we just discussed about diverticulitis, if there is some like very bad history which you don't know about, which you need to be careful about, you want to
Hmm.
see everything, you want to make sure that you do the safest. Those are the cases. And if the patient is morbidly obese, those are the patients I
Yeah,
would go for TAP. Otherwise, TEP works great in every other patient.
yeah, I agree. Next question. Is the effort involved in maneuvering the surgical instruments in a more restricted space the only reason for which TEP is considered more difficult than TAP?
it's not really the effort. It's just the about the way how you place your trocars, your incisions. I mean, it's interesting. There's huge variance in how we surgeons do TEP. I've seen surgeons doing 3 small holes straight in a straight line in the middle. I've
That's how
seen
I do it.
surgeons, yes, and I've seen surgeons doing like 2 in a straight line and 1 a little bit on the contralateral side once they develop that space. So it's every surgeon has a different way of doing it. Ultimately, you triangulate the instrument so that you can
Yeah.
fixate the repair, right? Like, so you triangulate onto your point of surgery. Like if your hernia is in the groin, you're basically your 3 instruments in triangulating, which includes the trunk. So
Yeah.
to have the best efficiency.
I think why people think TEP is more difficult is the anatomy is more difficult to appreciate, understand. Like I've done so many TEPs. To me, it's like memorized in me all the different relationships between where the pubic bone is and therefore where a femoral would be and therefore where the epigastric would be and therefore where a direct would be and therefore where indirect would be. Like to me, as long as I know where the pubic bone is, I know where everything else is. Like
That's true.
anatomically, like the pelvic anatomy is it's like a map and me. I can be blind and still know where everything is. But I think for a trainee, it's difficult to learn that anatomy. In fact, I remember there was I think it was like 10, 15 years ago, there was a talk given by, I think either Yickel or one of his underlings in the Netherlands. And they said that they would make their junior residents scrub in and hold camera for 1,000 inguinal hernias before they were allowed to operate.
Wow, that's
Just
an
to hold
interesting
camera for
number.
1,000. I'm like, wait a minute, how many hernias are you guys doing? But yeah, it's because the anatomy is so complicated. Whereas when you do a TAP, sorry, TAP, TAPP, people tend to be a little bit more comfortable with that anatomy because you can kind of, I don't know, they're more
You're
familiar with it. It's easier
I
to,
think
to
so. I
look
mean,
at.
I tend to agree on that for sure because when you're doing a TP versus TAP, when they're doing TAP, you're basically you saw the broader view and you're
Yes.
trying to peeling it down. That gives you some sense of comfortness for you to. But in general, it will be the same anatomy no matter whether you're doing a TAP or TAP. Well, TEP or TAP, it will be the same anatomy for the patient because both are posterior repairs, right?
Yeah.
So it's just a matter of getting comfortable in that zone or in that box, fixing it. Yes, definitely. As you said, you always start with medially for TEPs because that anatomy is always constant. Like your bone, your pubic bone, your rectus muscle, everything
Yeah.
is pretty much constant. Yeah.
Um, Off topic a little bit. Have you been told, let me rephrase.
Mhm.
Have you seen patients with complications after a tram flap or a deep flap, DIEP?
Oh yeah, a lot of them.
So, there's a Facebook group that has a bunch, a very large number of women with complications from the tram flap or deep flap. Sometimes it's a true hernia, sometimes because they've injured the posterior
That's
space.
right.
Um, but sometimes it's a denervation injury. So it seems the question here is, um, we have a lot of patients in our support group for ladies with complications from tram or deep flaps, and surgeons are approaching these laparoscopically. These approaches do not hold, um, either because the mesh is adhering to organs, they may have weight gain, the mesh seems to tear or
Mhm.
not expand. Um, I have my own thoughts about this, but what are your thoughts about
Okay, so
this
my
problem?
thoughts about, I mean, I have seen and I repaired like a whole bunch of the tram flaps and deep flap repairs causing
Yes.
hernias. I personally feel deep flaps are fare a little bit better than tram flaps because
Mm,
it's mostly because what happens is in when you're doing these flaps, they get denervation basically, and the
yes.
muscle gets atrophied in that area, and you get this hernia. It's
Hmm.
mostly looks like a very big, large diastasis.
Yeah.
I have repaired bunch of them, and I always end up going robotically in those cases. I
Mm,
take the peritoneum down, placate, because you don't really have the muscle up there. You have to placate the diastatic portion of it and
mhm,
put a mesh, like a wider heavyweight mesh to prevent. But I always end up telling my patients, listen, you lost the muscle. The muscle is the one who gives the shape for the body, like for your
mhm,
abdominal wall. Once you
mhm.
lost the muscle, you can put your new, I can fix that hernia with a mesh, but in future it might look great for the first couple of years, but it might bulge out. It's like if you take a rubber band, you keep pulling out, after a certain time it will slag, right? Like that's what happens. The scar tissue is not like elastic, it won't come back. It, once it gets stretched over a, because our abdominal cavity, I mean, people underestimate the abdominal wall muscle, but they're working constantly 24/7. You know, it's just like your
Yeah.
heart. They are constantly working. You're coughing, laughing. It puts a lot of strain on those muscles. So it will put a lot of strain on that scar tissue. And eventually, in future, it might bow out. But if it happens, we can always do other ways of fixing it.
So here's my take on deep and tram flap complications. So if you have a denervation injury, which is a large proportion of them,
Yes.
that is a horrible complication because any operation that's performed has to be done with the understanding that at the local area, that nerve, that muscle is mush. There's
Yes.
nothing you can do with a tissue repair ever. You have to use heavyweight mesh. Um, and it's an anterior problem. It's not a posterior transversalis fascia problem. You have to do it. So I'll do all those open. I just use their same um, tummy tuck type incision.
Yes.
And I do a very tight plication. It has to be super tight. And then put a very, very wide mesh in. And it has to be super wide. You can't just treat it like a hernia. It has to go to only healthy tissue and tissue that doesn't move. So pubic bone, pelvic bone, inguinal ligament, ribs. That's how extensive it is. And even those operations still don't hold perfectly. My problem that I see is that people address these like hernias, and they like to do robotic hernias, for example. I've seen people do robotic TARs for tram and deep flap complications, and I'm like, that's not the
Nah.
problem.
Yes.
To do a TAR completely ignores it may look good from the inside, but completely ignores what's going on from the outside. So that's, I think, what they're saying, which is laparoscopic repairs are not holding. It's
Mm-hmm.
not so much that they're not holding, it's the wrong approach. Trying to think of what would be a good analogy. It's like saying like my roof is open and
Yes.
it's leaking. And you're like, okay, no problem, just put a tent inside. Like if you're in the tent, that's fine, but your house is still got a hole in
True.
the roof and the whole house is destroyed. So to put a tent inside the house does not solve the problem of the big hole in your roof.
I mean,
So
that's definitely. I think that's a great analogy you
yeah,
played out. I mean, I mean, definitely, I agree. Like a lot. I mean, I have done both ways. Majority of the times, the patients end up going to the plastic surgeon because of the bulge,
yeah.
and because it's in the same area of they operated, and they're always like, and I've done this. Like they, hey, I will lift up the skin flap and could
Behind
you
you.
fix it? When they once they lift up the skin flap, yes, I will definitely fix it anteriorly. I would not go posterior at all. But if they're not, the plastic surgeon is not doing anything, hey, I cannot do anything anymore, then I just create the preperitoneal space and placate the muscle, then put the mesh on. I'm not doing TARs on these patients at all because, as you said, it's not a problem where the muscles tore apart. It's just a matter of denervation problem rather than anything else.
I mean, you can have legitimate hernias, right? And
Yes.
those hernias, especially with the tram flap, some of them are now called, I just saw one last week. It's a small pedicle tram flap. So they take a central pedicle, like the most of the rectus is
Hmm.
intact. They take a central rectus pedicle with their the vascular pedicle, a small piece of rectus, and then the rest is basically like a deep flap. So technically, it does include the rectus, hence the term tram. But those people that actually get hernias, right? And even those hernias still, it's an anterior problem. And I feel that it's not a hernia. To approach it like a hernia, it's not, it lacks the understanding of what the problem is. And that's why these people that just go like intraperitoneal onlay mesh, they put a mesh in. I have another patient that was referred to me recently from a deep flap complication, and they went in there and they did a perfectly good. She actually legit had a hernia, and it's just very difficult to get those really tight posteriorly.
Yeah,
Anteriorly you can do a very tight tummy
sure.
tuck. Posteriorly, it's not good tissue, and you can't do really good tummy tuck, and it doesn't give you the contour that you need and that these patients expect anteriorly. So I just suck it up and do it anteriorly.
I think, you have a great point by saying that, because when you're doing these repairs anteriorly, when you're plicating them,
Yeah,
it gives you a better contour than
yeah,
posteriorly, because
yeah,
you're inverting that laxity of the tissue. When
yeah,
you're doing the posteriorly, it kind of gives you a bump because you're
yeah,
tightening. That gives you the bump. That
yeah.
I can see that what you're saying.
Okay, that was a great, great more than hour, Prashanth. I'm sorry to take so much of your time. It's 8:36 your time. It's time for you to go home.
I know. There's so much fun discussing about hernias.
I
I hope
know.
a lot of people benefit from this talk. I think it's always a
Yes,
pleasure to have you.
agreed. Thank you for your time. I really appreciate it. And for those of you who joined us, this has been a great episode. Please go to my YouTube channel. This will be up in the next 24 hours. Go to @HerniaDoc, subscribe, share, like. If you like it to listen to podcasts, leave us a little comment so that other people can also find us on the podcast on Hernia Talk Live. Thanks, everyone. Follow me on Instagram at HerniaDoc, and I'll let you know about our next session next week with another great guest. Until then, thank you. And Dr. Sreeramoju, thank you again for your time. It was fun. I hope to see you where are you going to be at the American Hernia Society meeting?
Yes, I will be. So I'll see you back in Chicago, I
Well, I'll
guess.
see you in Chicago. All
Yes.
righty. Thanks, everyone. Bye bye.